everyone. So once again, I'd like to thank FreeMind for inviting me to speak again this year. And so I'm Commander Michael Banyas. I am the program manager for the National Institute of Minority Health and Health Disparities. And we're one of the NIH institutes, but even though we're the smaller one, we provide a lot of leadership, market guidance, and funding opportunities across the NIH that focus on health disparities populations. And I'll go into what are the NIH health disparities populations in a few slides. So we're one of the smaller institutes, but we work very well with all the bigger institutes. And you can come to us if you have a cancer, if your program is focused on cancer, aging, our main goal and our main focus is focusing on not drugs, but devices, services, and digital health and other means to help open up healthcare access and gaps, which are also market opportunities. And when I say market opportunities, for example, if you have a product and it's not reaching Latino populations or Asian populations, those are customers that aren't being served. And one of the things that's great about our SBIR program is that you can apply and say, I want to take this existing product and I want to focus it on bringing it to Asian populations, making it bilingual, making it more culturally competent. And I'll go, in the subsequent slides, I'll go into what are the identified barriers of health access that we've identified and that we look to in funding companies. So our institute, just another overview, is we promote research to understand and improve health of racial ethnic minority populations, advance scientific understanding of health disparities, develop and test interventions. It's all about, we love the small research questions, especially for phase ones, to test how to bring your product into these different health disparities populations to help open up access, and create and improve scientific methods, measures, and tools that support health disparities research. Now, NIH has several health disparity defined populations. And what is a health disparity? A health disparity is essentially someone is not getting access to a treatment, a drug, a service, and it's creating poor health outcomes. And when we look at our applications, some of the populations that it will need to align with are Hispanics and Latinos, rural areas, American Indians, Alaska Natives, gender sexual minorities, which is LGBTQ, socially economic disadvantaged individuals, such as Medicaid, WIC, Medicare. I love my Medicaid innovation concepts. African Americans and Blacks, Native Americans, Asians, and when you think of that about Asian populations, that includes American Indians, that includes Thai people, that includes Chinese, Japanese, all those Pan-Pacific populations. People experiencing disabilities, which was new in September of 2003, and then North African and Middle Eastern populations. So as I mentioned at the beginning, one of the things we look for in funding products, specifically for our phase ones, if you're taking an existing product and trying to make it applicable for this market, is it alleviating a physical barrier, such as is it opening up a healthcare clinic that maybe provides care to Asian populations? Is it knowledge-based, which is health literacy? Are you communicating treatments to people at a certain educational level? Infrastructure, economic, cultural. And the other thing we look at is that if a process takes A, B, C, D to equal healthcare delivery or access, how do you eliminate or amend a step to reduce friction to deliver your ends? So how are you creating innovation to deliver that care more efficiently to that market population and help alleviate these barriers? So just some examples of the safety net providers and digital health market opportunities that we fund. It could be health disparities research support. It could be clinical trials. One of the things that's built into our funding opportunities is creating products to help expand knowledge or help experience participant studies to clinical trials, remote patient monitoring, service to strengthen workforce and infrastructure, precision medicine. And then these are also the types of safety net providers that we look at funding products to help meet. Federally qualified health centers are a major important aspect for products that we're looking to actually fund. It's the largest primary care network funded by the government, and it receives a tremendous amount of government support, and there's billions of dollars in grant money that they get every year, and they need products to help carry out their mission within their patient populations and provide care to the community. So one of the things is that when people come and want to pitch me their idea, we ask for an abstract. It's easier to react to something in writing. It's easier to follow, and it's also, if we need to pass it off to our other NIH colleagues, it's easier just to forward that email. So, but how do you actually write one? So I came up with a small equation, and within the first 4 lines, tell the audience what you're doing and what you're trying to solve. For example, what is the health disparity population? What's the health inequity problem? What's the intervention and difference from the competitors? Why are you doing something different than someone else? And how does that help equal health equity and expand access? So those are like the major things that we look at is when we get an abstract, tell us the research question. Tell us what you're doing. We don't need 20 lines on why diabetes is a problem in this patient population, but just tell us what you're doing, because it's easier for us to now it's easier for us to then start providing you feedback, but also applying to the NIH in grants. Like, there's a lot of different strategies that we help our applicants with, like taking like a phase 1, which is a $300,000 grant, and that's just proof of concept, and dividing it up so that you have multiple opportunities to have smaller research questions to apply for the phase 2, the $2 million grant, which is the larger research question. So just some funding opportunities I want to lay out, because I know some of my other colleagues have talked about the omnibus and the process and the phases before, so I didn't want to repeat that for the audience. So 3 times a year, you've got January, April, and September application dates. Those are just general. We also have specific application dates for example, Innovations for Healthy Living, which several NIH institutes are signed on to. The next application date for that is June and December, and that goes to a healthcare disparities special emphasis panel. 2 weeks from now, I am hoping that our women's health research and health disparities populations, SBIR, funding opportunity is going to be coming out. Several institutes have supported that, and where that's going to focus, just as I talked about with market opportunities, it's going to help provide that market guidance for, particularly with women health research, to not only ensure that women living with the burden of health disparities and in underserved populations, that there is funding and seed money out there to create products for their needs, but to also talk about, yes, there's a lot of talk about menopause, there's a lot of talk about endometriosis, which is, serious health ailments, but those are the most common ailments talked about in a lot of these health research conferences. And we want to point light to autoimmune diseases, people with women with disabilities, how to create products for that. Clinical trials, how to build products for inclusionary clinical trials, how to place an emphasis on chronic diseases that affect women, but also creating those products that provide seed money to help reach these patient markets. Thank you very much. That's it. I just tried to be efficient because I know we're before lunch, and I know that line over there is not for me. It's for the sandwiches. So I've got time for questions if anyone. Yes, how are you?
Thank you. Is the second one, the NIMHD Innovations one, also an SBIR?
It is. They're all SBIR. Sorry. When I went on a couple minutes early, I was poised enough. Like, I was kind of like, ugh. But yes, no, these are all SBIR. They're all phase 1, phase 2s, and direct phase 2s. So does anyone know, okay, so phase 1 is about $300,000. You can apply for budget waivers. Those are proof of concept. I always try to encourage people, apply for multiple phase 1s. And you can apply for each of these with the same application. And what's great about, so you can apply for the omnibus in April and then use the same application to apply for Innovations for Healthy Living, as long as they're both considered not resubmits, they're both considered new applications. The other thing is apply. You're gonna get feedback regardless. I know one of my awardees is in the audience and she's been trying to get a hold of me for a week, but believe me, I can, yes, Amy, I know I need to have time with you. I am pretty accessible for the most part when I'm not traveling, but we're here to provide you feedback, and we're here to help put you in the best possible position so that when you go to that 3-person review panel, that you are placed in the best possible success so that you can get feedback to either get scored, have another institute pick up your application, or resubmit and move further. Yes?
Rare diseases under the umbrella of minorities?
It is, yeah. And I don't fund therapeutics for the most part. We do that. So if you come to me with a therapeutic, I'll have a discussion with my scientific director. We have funded therapeutics in the past. It's just we will work with the other NIH institute, and we're all very collegial, and we'll work together to put you in the best possible way for success. Like, this is all about discovery. It's all about, you're all taxpayers, and we want to make sure that we're here as public servants to help deliver that customer service so that you can be successful and help carry forth the NIH's mission. Yes, ma'am.
Can you please expand on that? If we have a therapeutic that we're really interested in their equitable trial enrollment,
Yes.
we can leverage your institute's
Yeah.
funding.
Yeah, and you know what? You could even, the clinical. So I had previously come to this position from the All of Us research program, and I was standing up the clinical protocol in federally qualified health centers. And it's a different way of actually carrying out a clinical protocol, and there's products that actually need to be created to help bring in diverse populations into those clinical trials. Like, I'm sorry, like my mom was a researcher at a major academic medical center. I've been reading, in fact, she used to enroll me in her studies. I've been reading patient consent forms for my entire life. They are complicated. And I'm a fairly educated person, and I couldn't even get through the All of Us one without even getting a headache. It takes an hour, but that's an example of a product or an efficiency that you could create. And if you're doing your research with your therapeutic, and you create a product or you create something, use that, sell it, create your own business, do a spin-off, use that money to help further NIH research and alleviate health disparities and create health access. Yes.
Sorry, I may miss your point. So the new women's health and research will have similar amount of funding like the above two?
Yeah, it's going to be, it all comes out of the $1.4 billion that NIH gives out every year. And I know there's going to be questions about the new administration. I'm just going to say this. Can't answer them, but our money is appropriated by Congress. So NIH has a mandatory spend off of whatever is appropriated by Congress. So but it will come out of the $1.4 billion. It's just certain institutes have set aside funding so that it's going to be it's going to be directed towards women's health.
And how much for one project or for one application?
$300,000 to $2 million.
I see. Thank you so much.
And that's why I say apply for multiple phase ones. $300,000 only goes so far. But you think of it as small research questions, and if anything, it forces your company to have that conversation about where they want to go. Because one of the things I like to tell companies is, you're not going to get a check right now, but think about what you want to use the money 9 months to 12 months from now. Because then, if you do get scored and you do get money, you're going to be ready to hit the ground running rather than kind of feeling like you're starting from behind.
That was going to be my question.
Yes, high scoring applicant. So if anyone has a question about how to write a good application, it's this man right here.
Thanks.
He rocked it. He's that good. I would totally ask him as many questions as possible.
I was just going to ask the question, like you can hold multiple or submit multiple phase 1 SBIRs, as you mentioned as well, with different research topics, I guess.
What was that?
Can you submit multiple phase 1
Yeah.
projects, even for the same institute, or do we have to submit it to different institutes?
You could, like I said, small research questions. So I thought some of my colleagues went over this again. So usually I try to skip through the rudimentary NIH slides. So with the omnibus, you can apply up to 2 institutes, but that doesn't mean that like another institute might come in and take that application. It's all like a big game but you can apply to multiple institutes. So that's why you can apply to multiple phase 1s for me. So say you're doing a product for like, let's say clinical research, or no, let's take Medicaid innovation. So each state has different Medicaid eligibility rules. So let's say you want to do a phase 1 to do a product in California and then one in Texas. Those are going to be 2 different Medicaid environments. Those are 2 different applications that you can propose. The research study will be a little bit different, but now you're going up to the blackjack dealer, if I could say, to use a gambling analogy, you're going up to the blackjack dealer, and now you're playing multiple hands against the house. But it also, this is part of the strategic planning conversation. It's like when this funding comes in, where do we want to go? And it's a good exercise in organizational management to have with your staff and your leadership. Yes, sir.
So on translational devices, so like an at-home devices for another indication that would specifically really benefit a disabled population, is that
Yes.
characteristic?
Yeah, like I get a lot of great devices where it's used for like X and, okay, so let's use this analogy. Let's say Apple is not a multi-trillion-dollar organization. Say that they're a startup and they're coming to me and we have this phone, but we want to build in accessibility issues to use it as a hearing aid with like iPods or something. That would be something that they can apply to us to enhance functionality from an existing device and translate it for a specific population. Or if you want to come to us and you're like, hey, there's a big market here in like the Chinese population, but there's different cultural competency barriers aside from language for like an aging product, that would be something we would fund because that customer market is not receiving access, which is leading to poorer health outcomes. And we're here to provide companies the support to help open up access and reduce the burden of health disparities in those patient populations.
If I ask you a different way, if there's a protected class from a federal perspective and we target a solution to that group, then that fits under your responsibility?
Yeah, as long as it aligns with those populations that I put up there. Yeah. Is that it? I had more questions last year. I guess I wasn't as good as last year. No, thank you very much for the opportunity, and thank you again, FreeMind, for squeezing me in. I really appreciate the opportunity. It's always a great event, and I'm happy to be back again.